I would suggest that where we're going with the technology is using tomography, adding biomechanics, understanding perhaps being able to diagnose keratoconus patients better, and then also determine when to treat those patients, and then perhaps even determine treatment efficacy. What do you all think? How would you change your practices as that biomechanical measure, for example, Corvus, becomes available?
I guess I'll start. I mean, I think anything that can help us catch ectatic disease earlier is going to be better. I mean, the sooner we can catch somebody who's at risk or high risk or is already starting to progress, the sooner we can get them treated, I can only see benefit to that in the long run.
And I think if we take it even one step further, so George is the medical monitor for the phase 3 EPION study for keratoconus that Avidra is initiating. Obviously, Oculus is developing the Corvus technology. I think there will be future options, assuming that the efficacy endpoints for that phase 3 study are met, to also have various treatment options available for patients besides just the epi-off treatments that we have for now. So again, I think we're going to see changes in our practice patterns, perhaps. And so from that perspective, I just want to ask a question to Dr. Belin to try to, again, simplify for all of us what often when we look at tomography can be complex, and we all recognize there are various components of what we use in our clinical decision-making in making a final decision on whether a patient has keratoconus or may be a candidate for LASIK, PRK, et cetera. So on the Belin Ambrosia display, on the bottom right, we all are used to seeing yellow or red and knowing that there's a concern with the final number. You have suggested in the past that there are levels depending on age, because with age, tensile strength of the cornea changes. Can you give us some suggestions on how you kind of approach that?
Right. Realize the final D, which is what he's referring to, the bottom right, just arbitrarily turns yellow at 1.6 standard deviations and red at 2.6. Those are arbitrary points. You have to look at the number. And in my practice for years, we've made those age variable. So if you have someone who comes in at the age of 60 and has 1.8, I'm not really concerned. When we looked at the numbers and actually did some data, if you want to have a non-simple answer, effectively, if you take a 30 to 31 as a 0 point, for every year above 31, you can subtract 0.05 from the D, and anyone below 30, you add 0.05 to the final D. We'll give you what we call an age-dependent final D. It's not currently available, but that is hopefully what we will be doing in the future, give you an age-dependent variable. And
so say that again, above 30?
Basically,
subtract
30 to 31
0.5.
is your 0 point.
Right.
Above that, because the older you are, the less risk you are at. We subtract 0.05 from the D per year.
Okay.
Up to, I think, 45, 50. And below 30, up to 18, you don't go beyond that. You add 0.05. So higher risk on a younger patient, lower risk on an older patient.
Okay. And so Katie, perhaps you or George or Brandon can comment on using the ABCD that Dr. Belin went through in your practices. Any thoughts on its utility?
Well, I agree. I think, you know, as we become more experienced with cross-linking and with new technologies and development, we are going to have more opportunity to screen patients at very young ages and catch keratoconus or very early signs of keratoconus at young age when we know we haven't lost any vision. And I think that we can use potentially new treatments, potentially going forward, to maintain the cornea, and finding these parameters are extremely important because they're so sensitive.
I absolutely love the ABCD progression profile for a couple different reasons. We've been using the Pentacam for some time, but it's always, and I'll do my talk later on talking to the patient, but will bring up the Pentacam image and try and give my patients a quick lesson on what this means. And it's basically red here, bad, you know, but now you can actually show them the bars. And you're like, look, this is your stage 2, a stage 3. And it doesn't take a lot of time for you to analyze that data. It does it for you. So it really allows following, you know, not only the diagnosis, but also following somebody very easy that, you know, the physician can use and the patient and family can also understand very easily. So that has been, I think, one of the biggest bonuses of some of the new software on the Pentacam that we have.